When you say compassion, what comes to your mind?
Compassion, it means, empathizing with a person's situation, understanding what they're going through. In the ER, a lot of people are having the worst day of their life. And it's like understanding that
ERs generally are very chaotic environments, right? How easy is it to practice compassion or be compassionate?
it's that sometimes you forget that, this is what I do every day. This is just my life.
Compassion is not just for the patients, right?
The system makes us be the only ones that have to be. I could
I
talk
could
about
talk about
metrics and
metrics
the
and
hate
the
for
hate
them
for
all
them
day.
all day.
Everyone was once a baby who hopefully had a mom that loved them and a dad that loved them, and they ran around in diapers or naked, and everyone laughed. And again, we didn't speak any language, but he knew who I was. He would give him a big hug, and you know, uh,
Hello, Dr. Joshua Brown. Thank you for joining us today and welcome to the show. How are you doing today?
thank you for
Thank you for
having me.
having
I'm
me.
I'm
I'm
doing
doing
well. It's
well.
a pleasure to be here, and again, thank you for having me.
To start off, I would like to know a little bit about your education, your background, and the kind of work you do.
Sure. Yeah, I grew up. I was born in Brooklyn. I moved to Texas for a little. My dad was a teacher of medical school down there, and then we moved to the Philadelphia area. I currently work as an emergency medicine physician in Bryn Mawr Hospital. It's a western suburb of Philadelphia, as you know. My dad was in the system as a critical care doc, and this is kind of where I grew up. I went to Pittsburgh, University of Pittsburgh, go Pitt for college, and then moved just a little north to Erie, Pennsylvania, LECOM for medical school. And currently, like I said, I work mostly like my main job's an emergency medicine physician, but I am pretty passionate about medical technology. I advise two startup companies, one dealing with postoperative adhesions right now, and the other working on AI, EKG, and not really interpretation. They use an EKG to determine, coronary artery occlusion. Really cool stuff. So that's a little bit about what I do. Yeah.
Great, that's great to hear. So, I heard that your dad was in the system and he was a critical care physician. But coming to yourself, what was the main reason that led you to medicine? What were the things that you wrote in your personal statement and what led you to medicine?
Oh man, so many years ago, and the system is difficult, so it's hard to remember what drew me to this profession. No, I'm just kidding. Multifactorial. I got to see the impact that my dad had on his patients. He was kind of a pillar of the community. A lot of friends and family would go to him for advice. He was able to help a lot of different people. At the same time, economically, you're able to take care of your family. That's always something I wanted to do. I want to make sure my kids want for nothing. Now I have three of them, so definitely need to make sure of that. And then I always kind of had that math science brain. My wife, for instance, she's multilingual, speaks three languages, like learned Latin when she was studying, and I've tried to learn these languages to speak with her so she can stop talking bad about me behind my back, and I just can't. But when it comes to like math and science, my brain just works that way. And then what drew me to emergency medicine was specifically was, it was I realized that I didn't like anything. So it was the thing, I might as well, no, I'm just kidding. I wanted to be I wanted to be that doctor you went to when you were sick. So if you were in an airport and something happened, I wanted to be that guy that could help you. If you were, if my, friend's child needed some help, I could be the one. And I really feel like that's what I am. I'm kind of a jack of all trades. And yeah.
That's cool. I think you answered my next question too. So
Sorry.
that's awesome. All right.
Hope the joking is
Joking is
okay here.
okay here. Very much. I would love that. I would love that. And we would definitely want to have fun. And thank you for bringing that fun into this. So, coming to compassion, right? I know you and I have talked about off the screen multiple times but when you say compassion, what comes to your mind? What are your thoughts like?
Yeah, it's such a interesting topic in medicine in 2026 because medicine is driven now by profits and all these decisions that really have nothing to do with compassion and sometimes don't even have to do with, how best we can help someone. But when I think of compassion, it means, empathizing with a person's situation, understanding what they're going through. In the ER, a lot of people are having the worst day of their life. And it's like understanding that and what their families are going through and their fears and anxieties of what's next. And to just kind of be able to empathize with that.
So yeah, I think ERs generally are very chaotic environments, right? There is always on the run, you're on the go. There's so many things. I mean, you have to attend to so many things at the same time, and it's a chaotic environment. How easy is it to practice compassion or be compassionate? And what matters there most? What are your thoughts about that?
It's difficult. It's difficult for a number of reasons. One, it's my everyday life, as you know. So it becomes hard to sometimes you forget, that it is somebody's worst day. It is somebody's fear. This is the first time that they're being told that they have, a brain tumor. I've told hundreds of people that. And, that's an extreme example. If I'm telling someone they have a brain tumor, I'm obviously, I'm getting down on their eye level. I'm putting my hand on their hand. I'm trying to really, console them. But ignoring the extreme example I used, there is a truth to, I'm joking around with the physician assistants, my colleagues, texting on my phone, laughing with the nurses, while somebody a few rooms down is finding out that, they had a miscarriage or they have cancer or, their heart isn't beating quite as well as it should be. And so it's not that it's hard to have compassion. It's that sometimes you forget that, this is what I do every day. This is just my life. And someone else is experiencing this for the first time.
Yeah, I think that is one of the hardest part, right? I think we are generally speaking, we are in this autopilot mode.
It's a good way of putting it.
A lot of the times we are on the go. We don't stop much or take a pause sometimes, not even take a possibility to take a snack break or a pee break, right?
Very
And
true.
on the go in this autopilot mode. And that's where I think what in situations like that, what do you think can help to enhance that? Or let's go back actually before that. Do you think a compassionate approach is essential overall in the healthcare systems and in the age of AI in 2026?
That is such a tough question. I think you've asked me this outside of this context before, just in passing. I should have thought more because I should have known this was going to be a question. Do I think it's important? I do think there is a role for it. I think the role for it is in those extreme examples. Someone is having, they're finding out they're having cancer. That is a truly life altering situation. I get down, like I said, make eye contact, let them know they're not alone. The system's here. Me as a person's here for them. And there's other examples of that too. People that are, let's say have not cancer, but they have diverticulitis and they found out that they've perforated their bowel and they may need a surgery and an ostomy. That's life altering. They're scared. And that's another example of someone that needs compassion. So yes, there are moments where compassion is needed. Unfortunately, I do think that society asks a lot of their doctors and our, administration nationwide asks a lot of us as well. And then we're scored on that, et cetera, with like Press-Ganey scores. And they want us to sometimes be compassionate about things that ultimately lead to less compassion overall. A patient comes in with a stubbed toe and maybe they're a little histrionic about that. They think it's the worst day of their life is what, administration might tell us. And you should be compassionate to that. And it's very hard to be compassionate to someone with a stubbed toe. It's not that I don't feel bad that their toe hurts, but it's hard to have that same level when I just told, a mom that she lost her baby. And I think when you are asking us physicians to do that, to have the same level of compassion for a stubbed toe or a paper cut to the hand or a laceration or whatever it is, as the person that had a miscarriage, I think overall compassion comes down.
That is so true. Yeah. I don't know if I can talk much about this chapter or a paper cut, but there are some situations where I think some of the situations that we commonly, we'll go back to an autopilot question. I've not forgotten that yet. But if we talk about some situations where we come across this chronic pain, right? A lot of unfortunate situations, but still illicit drug use and withdrawals, right? diabetics who are not able to, type 1 diabetics, have not been able to manage their diabetes. What about such situations? What are your thoughts surrounding that?
They're challenging. And, it was many years ago, in the emergency medicine world, there was a podcast, there still is, called MRAP. Have you ever heard of it? Some of our key opinion leaders, thought leaders, kind of the emergency medicine community have made this podcast, and it's really well done and famous. But they had this one episode on it that I'll remember listening to, and it's about sickle cell patient and the chronic, what they go through. And, we as physicians can oftentimes, and we see a lot less sickle cell in my population now, but where I did my residency, I saw it all the time. And I remember sickle cellers here again. But what they went through to get to that point of kind of that almost pain-seeking visit, for lack of a better term or word, is, they might have had a stroke. They might have had acute chest syndrome. They might have had multiple pain crises or lost a limb, avascular necrosis, whatever. They've really gone through a lot at a young age, and they are in pain. And this podcast was really good. And it did open my eyes, and for a while it changed my mind, changed my mind, but then the system kind of bogged me down. So it's to circle back to your question, these people are challenging. I try to have compassion for them, but at the same time, it is difficult in the emergency setting. I feel like, it's sometimes a waste of resources for not sickle cell necessarily, because but chronic back pain, they're on opioids. They don't call their primary care. They don't call their surgeon. They come to the ER, and it's sometimes hard to have that compassion for them. I feel bad that they're in chronic pain, but it's challenging. Sorry for the rant.
Not at all. Not at all. That's very, I think that's how the progression happens, right? So coming back to the autopilot, and this is where, so we are generally in that autopilot mode, and sometimes it's hard to remember that these patients could have lived a life that we wouldn't have seen all along, right? Just like how you explained the sickle cell patients or even any chronic pain situations, they're there for various reasons. But how do we think we can just remind ourselves that you said that podcast actually inspired you and you were actually able to do that for a little bit, but then went back for various reasons? So, how can we remind ourselves more frequently that these people probably need more compassion as well? And that one act of compassion could, we don't know when, whose life will change, right? What are your thoughts?
Again, challenging, especially in the emergency setting, because the answer I want to give is getting to know who they are. How did they get to that? I always found it interesting. How does a person get to the person they are now? At one time, now having young kids, I think about it a lot. Everyone was once young. Everyone was once a baby who hopefully had a mom that loved them and a dad that loved them. And they ran around in diapers or naked, and everyone laughed. And, all these patients are that too. And they once had dreams and aspirations and whatnot. And they probably have a family. And it'd be nice, you get compassion when that stuff gets brought to the forefront and you realize they're just a person too. The issue is, for me in the emergency department, is I don't have time for that. I don't, unfortunately, have time to take a dive into who they are as a person. And so my answer is to getting to know them better. And I don't have a solution to how to do that without compromising, dealing with a situation that's, a little bit more acute or whatnot.
Got it. Yeah. So, yeah, I think that was a beautiful explanation. And again, yeah, I think having that time, right? There's a topic, there's a concept called time affluence. I don't know, have you heard of that?
I have not, no.
Okay, we'll not go there today, but probably another another time. But coming back to those moments where we want to know them more, and but you said I don't have an answer how to do that, and especially in the time of the situations where in emergency situations where you're running around and constantly busy and chaotic, it may not be possible. But coming back to the metrics and the time efficiency, right? Again, we're in this. What's that?
I could talk about metrics and I hate for them all day.
All right. So coming to that, do you think, I know we're in this world of metrics, efficiency, right? How do they affect our care? And What are your thoughts? I mean, I'm going to bring in some evidence in a little bit, but what are your thoughts about with compassion and metrics
Sure.
and the physician well-beings, burnout, patient experiences? These are the common things we are seeing and common challenges, right? So what are your thoughts? And any inputs on that will be great.
I think there's a place for metric-driven outcomes if it's the right metrics. It is important that we get antibiotics into our septic patients early. It's important that we get TNK in as early as we can to our stroke patients. Ideally, we'd want to see our patients as quick as we can, so door to provider time or whatever. But it often ignores a reality of what is best for the patient. And it's great to get TNK in a patient in 45 minutes. That's like kind of our cutoff, right? But could we prevent one medical error if it was 47 minutes, and by asking one or two additional questions and realizing that sometimes we have to call 6 people to get the answer if they're on Eliquis or not, and not get a ding because it took that time and we did what's right for the patient? I think the answer is yes. I think these metrics are they're too rigid. They're supposed to broadly paint a picture so we can make some general adjustments, and they're too rigid. You didn't do it in 45 minutes, bad. You did it in 45 minutes, good. And, I think that's a problem. I think that metrics around, Press Ganey, like how the patients perceived their care was, I think in an emergency room setting is just completely ridiculous. With wait times the way they are, and it's not our fault. With, what is going on? It's loud, there's beeps, you might not get a bed, you're uncomfortable, and patients are unaware of what's going on behind the scenes. And they tie that to our salaries or pay by the government. They tie it to, how well we're, perceived by administration. I think that's a dangerous game to play. The other issue, and I'm going a little bit of a tangent into Press Ganey, so I apologize, is, Press Ganey's is, they survey for the ER anyways, patients that are discharged. So that patient that I gave TNK to and saved and their stroke got better, or that cardiac arrest that, we did CPR and saved them and they're now alive, whatever, a UTI that we got better with antibiotics but needed to come into the hospital, they never get that survey. The only people that get that survey are that chronic pain patient that didn't get the third round Dilaudid, or the stub toe that was annoyed they waited 6 hours because other people were more important, acuity wise, I mean, by importance. And that causes its own issues. So I'm going to stop there. A little sidetrack on Press Ganey.
No worries. So that's so true. I think the question, I mean, last time when I was having a conversation like this point of insurance companies and how they give out money or like the whatever payback to the hospitals, this discussion came out, and I was thinking I would really like to talk to the insurance. I mean, whoever the companies that are running the insurance, and what are the challenges that they have? Do I know? I don't know. And I'm very curious and keen to understand their perspective and angle. Similarly, I think,
What
yes.
size yacht can their CEO buy compared to the next size yacht? Yeah, those are the challenges. Make so much money.
I do hear that. I do hear that. So coming back similarly, I think it's interesting. I think when Press Ganey or all these organizations came up with these, I mean, have they had this emergency room or the group of physicians which actually represented the whole sector, right, of healthcare? Or like were this few people who came up with? Nevertheless, the point that I wanted was we are talking about problems, right? Or the challenges that we face.
Sure.
But if we want to look into the solutions aspects of it, right, what could be some of the solutions that we could from the emergency angle and the metrics angle, and at the same time being able to deliver the care and keep up with everything and keep up with.
I mean, we joke about it in the ER. It's kind of a national ER joke. It's not just local. But the first question is, but did you die? That person with a stub toe goes home and writes on Facebook how bad their experience was. And, I'm saying that a little tongue in cheek, but, the first metric should always be how good is the care? And that seems to never be a metric. I mean, it's not, sepsis is a great example, a little tangent again. I sat on the sepsis committee at my hospital for many years. I had to leave it because we kept falling out no matter what I did, because it wasn't the care that was bad. The care was perfect. It was how we documented that care. And it needed to be the exact words in the exact right order. If the order of the words was wrong, we got dinged. And it became more about just checking a box than the care. The care was perfect. And so, the question or the answer to your question is, the metric should be, first, are they doing a good job? And if that was the number one thing people cared about, I think it would be maybe easier to care about some of the other stuff.
I actually love that, Josh. No, I mean, I think I want somebody to actually listen to this and the next few things I wanted to say. So I've been having discussion with the team around in the hospital, and I think around our adverse events and the safety events. And I think at some point, there was this blame and punitive culture. And then I think they're saying it's just culture where we are trying to find both the individual and the organization issues and trying to fix. But I think this is where my compassion part comes, right? When it's very similar to what you just said, the good thing. I think the more we try to pick out good from people, the more we would see. And this is very well known in parenting too, right? Everybody who has a child would have gone through. The more we want to see a good in somebody, that's what we want to pick out.
Yeah. Positive reinforcement.
Right? Positive reinforcement. But it's so interesting. I mean, again, I've not gone into the details of Briskini, but based on what you're suggesting, maybe that's what we would want to. I mean, people should start thinking about to put more positive aspects and looking at those positive aspects as well. So
I was talking to my nurses the other day, and they were saying that, hung in their nursing lounge was Press Ganey comments. And there were 10 comments, and 8 of them were negative and 2 of them were positive. That's just going to make people mad. We are busting our tails off. These nurses bust their tails off. And, that isn't a constructive way of getting the message of what maybe the concerning things in those press gainings are. But it sure is, and it's not going to improve. Yeah, it's not going to improve anything. It's definitely this heck going to piss them off, though, and make them want to quit and move on.
I do agree so much. I mean, that's so true. I think everybody's working hard. Nobody's not working hard. And I feel even if we see somebody as the most, I don't know, for a lack of a better word, lazier on the lazier side person, they're trying to do the best no matter what for their capabilities at that point of time. And if we want to get good out of even that person, we have to try and find that good. And we have learned all along with our children, but I don't know why. Probably system should start thinking differently and doing differently and for the best and see. And hopefully you could be a change agent. Towards that solution.
It's difficult in this world to be a change agent anymore. Things are so set in their ways. It's hard.
Every change starts somewhere small, right?
Sure.
And I think the more of us think of that way, I know we are all busy with our families, right? With our work, we're busting our butts off. Is it? I don't know. I don't use that term often. But going back, I think we'll go back to the compassion. So I want to know, are there any, compared to the earlier years of your life, right? Again, we talked about systems, the issues, the metrics, and how they've been not supportive. So if we go back to the earlier years of your life to now, how have you think you have changed over the course of your journey?
Yeah. You should bring my wife on now to talk. I mean, I'm less empathetic. Well, let's talk the good. We'll start good. I'm more confident in my abilities. I, understand what my primary role should be. And I think I'm very good at that role. And I think I've really at the, peak of my career, right? Just, far enough out of residency to have kind of mastered my skill, but not far enough out where I'm lost on all the up-to-date stuff that you learn. And so 7 years out, which is what I am, I think I'm really flying high as far as a practicing emergency medicine physician. What I've lost is empathy, compassion, and not just in the hospital. And that's why I brought my wife up. I mean, it is very difficult to go home after talking to 35 patients a day, hearing everything from you have a brain tumor to I stubbed my toe, to a miscarriage, to a urine infection, and then go home and I say, hey, hon, how was your day? Hey, kids, how are your day? And, the little one cried over spilled milk. And it's like, another complaint. So, the empathy it's hard both in and out of the hospital. I think that's the biggest thing I've noticed about myself.
All right. That is kind of on the sadder side.
It is. I'm being honest. It's an
No,
honest.
that's good. No. That's exactly what I would love to have, the conversations that I want to have. So, I mean, and that is where the question, have you ever questioned why that's happening? Am I taking my work home? Is it all those energies? And
I think it's I'm only, what am I, 36? Oh, I'm getting old. But, I feel like society has changed a lot. I didn't live in the 60s. I didn't live in the 20s. I didn't live in the 1800s or prior. But I feel like people used to be more able and willing to deal with some issues. And now in my role is in the ER, it's almost like they've never had any adversity in their life at all. And that is just so taxing to have to be like, try to comfort someone with that. Like the amount of people that come in with flu-like symptoms, you've never had a cold before? Like it's mind blowing. And then it wears you down to like, see, we just got out of cough and cold and flu season. I get it. Some people do get sick and I have compassion for those people, but it wears me down trying to fake the compassion, which is unfortunately what I'm doing to meet that Press Ganey score, to make my hospital happy so I don't get talked to by my boss, and then go home and essentially have to fake compassion over spilled milk, where most people, I think, don't have to fake it so much at work. And then they go home and they say, oh, yeah, that spilled milk. I could fake it this one time for my wife. That must have been really hard for you. And it is. I don't want to discount my wife. My wife does, I could not do what she does. I'm not saying that we got 3 kids. She is, she's a saint with what she knew. I could not do that. I'm not disparaging that or any mothers. I'm just making a point for any of your listeners out there to not harass me on social media or whatever.
I get it. So I think this is probably where I mean, I don't know if this is or not, but have you felt that, is this burnout? Is this the sensations of, is that it? I don't know.
I think burnout's such a cop-out term for like what it really is. Like, I'm not burnout. Like, I have 6 other jobs. I do legal work. I do med tech work. I invented a little device that I am working on getting a patent for. I applied for my New Jersey license because I have another opportunity in New Jersey to do a side gig. I'm not burnout. That's such a cop-out. What it is a total systems failure, a total just nonsense, the way we're treated. They took physicians and they took us from being, this really incredible group in the 1960s, probably your thought leaders of society and well-regarded in society. And they basically made us, hated by society, hated by nurses, hated by administration, hated by our patients. And I feel it every day, unfortunately. Maybe it's just an ER thing, but.
I think what made that transition from thought leaders to where we are today?
Definitely, there's something to do with like the rise of administration. I don't know if you've ever seen that graph. I wish I had it for this. It's like cost of, healthcare in America. And, the bottom shows like physician salaries, and it like barely moves up from like 1970 to now, I think it is. Like maybe it moves like that, just like a little widening. And administration is like that. And it exponentially grows. I think that has a lot to do with it. Again, I think the population has become weak, for lack of a better term. It's I think that we see a lot of actually the negatives like social media and technology advances, because we've now moved into a world of like instant being instantly satisfied. Excuse me, I'm losing my words. And so from my perspective, again, I'm an ER doc. Everyone wants the answer today. They don't want to wait for that CAT scan. They don't want to wait to do it outpatient. The primary care doc doesn't want to wait to know if they missed, something. So they send their patient to the ER, and it's, that's a big part of it. Obviously that ties into then legal and lawsuits and stuff. The primary care doesn't want to wait a week to see if they missed an appendicitis because and get a routine CAT scan because they're also afraid of being sued. So it's not just like, I want to know for me, I want to know because I don't want to, the legal responsibility. And I'm starting to ramble. I almost forget the question here. Sorry.
No worries at all. So I think, how did we move from 1960s to 90? The day to day is the question. But that's all good. I think I got the point, and how our healthcare costs and how it probably changed.
Insurance too. And, I'm curious, if you don't mind me asking, are you asking this? Do you want to know my perspective as an ER doc, or do you want to know my perspective in healthcare in general, or both, or?
Together, your perspectives from all angles is what I would want to bring in more. I think my learnings, as I've been looking into compassion, right? I've been looking into evidence. Initially, my idea 2 years ago was actually to do a podcast. I've changed myself significantly over the last 5 to 6 years for various reasons. And that change actually has started letting me see people differently, situations differently, scenarios differently. I've moved from judging those patients with pain seeking and the illicit drug use to understanding. And I think, and that sometimes when I sit down, fortunately, I have more time compared to an ER doc to sit with my patient. And again, I think it's balanced. Some patients don't need that much time, but some patients do. And so when I sit down and I go deeper into their stories, it's heart-wrenching sometimes. I think, and just listening to them, I've heard so many responses. Just listening to them, they feel so different and so better. And I feel that, and I think my joy in every moment of medicine has increased much more. And that has only happened in the last 5 to 6 years. You know that I used to give a lot of trouble to my ER colleagues and taking patients, right? Accepting patients. But again, how I approach, and when the patient is not worked up completely, if I'm presented by a physician assistant, then I am able to sense that they're trying to do their best no matter what. At that point, for their capabilities, everybody's not the smartest. Everybody's not the most capable person or efficient. And for their capabilities, they're doing the best no matter what. Nobody's generally, though, they don't want to be lazy or try to be lazy. It's just like their capability. So understanding that started making me think differently, and all that actually. And then initially it was just the podcast, but then it's like I'm talking about myself. Then actually I was pulled into this evidence surrounding compassion. If we look, there is more and more evidence emerging, especially in the last few years. I see that a lot of our problems are the challenge, the lawsuits, the financial turnover, the patient experience, treatment outcomes. So all of these are tied so much with compassion. And I feel like we're behind the wrong metrics and wrong, the inappropriate ways of delivering healthcare. And I know we talk a lot about time, but sometimes it's just the intention and the attitude. Yes, you do need to spend a little more time with certain people, but other people we don't have to. So in general, it will extend a little more, but it may balance out. So I think that's where I come from. So, but definitely, I want to know from your perspective, from the ER perspective, from in general, I want to understand more. And again, this is what I've learned from the evidence aspect of it, right? But I want to learn from, I don't know, at some point, I want to bring in the people from insurance companies. Or we'll see where this goes. But so I just want to bring that out. And I see that. Yeah.
Part of, the issue also is the system makes us be the only ones that have to be compassionate. The hospital says, I'll give you an example of a story that's just like, it's mind blowing to me. I had a patient yesterday, we'll stay away from any HIPAA identifying information. They fell like a week ago, a subarachnoid hemorrhage, found a week later when I saw her yesterday, can't get out of bed, dizzy, can't walk. The dizziness has been going on 2 days. So 5 days after the bleed, presumed when the bleed happened. I can't get her admitted to the hospital. They say, repeat the CAT scan, it's stable. She can't stand. She has a brain bleed. When did we allow as society that to be discharged? It's mind blowing to me. And then why is the hospital then putting it on me to be like, you need to get 5-star press ganey. You need to be empathetic to the patient. And who are they going to write the bad review about? They're not going to write it about administration or the hospital. And this is nationwide. I'm not disparaging our hospital. This is a nationwide issue, or the insurance company that won't pay for the admission or whatever, or the consultant. They're just going to yell at me because I can't do the thing that I feel should be done. And, that's a problem. I could go on and on.
No, 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 but these are all very valid points, right? Again, I think, how did we get here and how can we get out of this? I think I don't know if this continues and deepens to a state. And yeah, and these are some of the reasons where we don't feel satisfied with the job that we do. And if
Yeah.
that patient, I want to help, but if I can't help, right? Compassion is not just for the patients, right? It's amongst the colleagues, the staff, or nurses. And if we think at the administration level and the leaders level, the support and the care that they provide and how it dissipates down across, right? How can that be practically seen? I mean, how can it be visible, or what are the practical ways of the leaders supporting or being compassionate to their staff?
I think good leaders are there in the tough times. It's really easy to be a good leader when things are going well. When the ER is inundated, it's nice to see a friendly face from administration saying, "Hey, I got your back. It's all right that it's like that. I'm going to go out and talk to the waiting room and let them know, you know, we're working our best out here." Or, you know, it's hard when you don't see a lot of people and you just get emails, "Oh, the waiting room's a problem again, blah, 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 blah," or whatnot. And again, I'm not saying that about my hospital or anything like that. I actually was just talking to one of our specific hospital's top leadership and telling them how much respect I have for him. And I truly meant that. We had a really nice convo the other day. But, that's one thing. And then for colleagues, and it's interesting because when I talk to my friends at other hospitals, ER doc friends, and when I'm on ER doc forums, I think ER docs in general feel pretty beat up by how they're perceived by their colleagues or the public. Like, we're kind of like a jack of all trades, not really an expert at anything. So people kind of look down on us. I don't have that issue at where we work. I'm not really, our work environment, I don't feel like you guys treat us that way. You as the hospitalist and then our consultants, I'm treated very well. So that's not my issue, but I've heard that being an issue with others. My major issue is these metrics and the society, unfortunately, and what they expect of us.
You remember you inspired me to say when I was getting frustrated about things, right? You said you can't do it at an individual level, Siva. You said you have to do it at the system level. So if you're getting frustrated about metrics, there's something you're doing you said 7 different things.
Something like that. I'd have to count it all out.
So put this in too.
Not
Don't
that
get
passionate about it.
you're getting frustrated about it, right? So
Well, yeah, I shouldn't say I'm not passionate about it. There's so many issues here. I wouldn't even know where to begin. Like, good for you for trying to tackle it. I could go on and on with the struggles of ER and what caused the lack of compassion. I don't want to bore you.
actually, we'll come to that point. Actually, what can be done, right? But going back to the administrative staff and walking out and talking to patients or the docs or the staff, I heard this quite a bit, actually, from different angles at different times and how that would make a difference. I don't know how frequently, in general, across the nation, how frequently leaders come down and do the walk and do the talk and check in. That would be great if more and more leaders start doing that.
Yeah, it's not the 5-minute walk that we, through the ER, like, "Hey, nice to see you. Good job." That's not what I want. Like, come down for 6 hours and sit with me. Know what I do, learn what I do, you know, walk out into that waiting room, sit out there for an hour, talk to the patients while they're waiting, talk to them when they get brought back to the room, really understand the environment that you're in charge of. It's a lot of it is just looking at a number. I feel like, a lot of people just see, 50 people in the waiting room, 6-bed ER. That's their understanding of it. They don't really understand what that means. Coming down would help that.
Yeah, I mean, 6 hours probably. If we say 6 hours, it's not going to happen. We'll probably ask for 1 or 2 hours. An hour, not 5 minutes, but an hour. So, hopefully, I think they'll start coming for more than an hour, when 35 minutes. And, I know, I think, we're going off. I
Oh,
do
sorry.
No, 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 stop. I do want I think generally we're all people's person, and there are situations where we feel extremely proud and happy about what we have done, especially when we go I mean, immediate zone or work, and do something for our patients or people around. Are there stories in your life that you could share with us?
There are there's one story where there's multiple stories, obviously, but one in particular that I know you're referencing because I've told you
No,
about it.
I would like to hear I mean, different stories too.
There's another one where I didn't do anything per se, but it affects me to this day still, and I still check in to see what's going on with that person. Just I remember their name, and I once in a while Google to see if they are still with us. And last I heard, they were. I have to be very careful. I'm going to try to do this without breaking HIPAA, but essentially, it involves a pregnant person. They were the same week pregnant as my wife was when we had our first kid, and I diagnosed them with an unfortunate uh, type of cancer that seemed like it was going to be terminal in weeks. It caused obviously a lot of complications because the baby was in utero, and how do we even start radiation or chemo? Should we deliver the baby early? I think they were early 20 weeks, something like that. And so talking about compassion, that is something I have, has kind of stuck with me ever since then. That was, like I said, 5, 6 years ago. And every 6 months I do a Google and just see how they're doing.
I mean, have you ever reflected why specifically? And
Yeah, I mean, I think like they were in the same situation as me, excited to have their first kid, and like they got hit with this like life-changing news, and that could have been me, or
yeah,
could have been my
and
wife.
right.
Yeah.
And I think that's so true. I think it's that connection you made, the connection beyond that patient physician relationship, right? I think that probably stayed. I mean, this is my theory, but
Yeah.
uh, are there any other stories that stay with you?
Yeah. So, I had this gentleman who was dying of terminal cancer. I was working overnight. He came in at, I don't know, 2 in the morning, maybe 1 in the morning, something like that, with his wife, and basically said, you know, I need my ascites to be taken care of. I can't breathe. It's filling my belly. It's pushing on my diaphragm. He was not doing very well. It looked like he, would pass in the next few hours to days. In our ER, paracentesis is certainly a skill that I have. It's not a skill we routinely do anymore. It's kind of, fallen into the interventional radiology world, and certainly not like a therapeutic tap, a diagnostic for SBP, of course, but not therapeutic. I don't even think we have the equipment to do like in our ER to drain. Like there's a whole suction system and big bottles. And I said, I'll meet you overnight, or, for the rest of the night. They'll tap it in the morning. You'll be good. And he, was telling me like, listen, my son's playing his last, or I don't know if his son's last, but my son's playing football tomorrow, and this is the last game I'll ever see him play. I'm going to die. And I said, and he's like, I can't get admitted. And I said, okay. And I sat there with the needle in him for, I don't know, an hour or so, and just pulling out fluid on him just so he could, you know, be able to go home and see that last football game with his son, watch his son in the last football game.
guys, I think a lot of conversation were giving goosebumps, the one before and in between. But how did you feel after doing that? Was there any difference or?
Yeah, it's there's one of those stories you go home and you tell, you tell your wife or something different that you did that day, something like truly, a lot of times I think it's interesting. Like I feel like I don't help anyone ever. It's obviously not true. It's just like,
It's
again, it's what we do every day. But that was something you could like, objectively say I helped someone. I changed someone's life that day. You know, he was grateful. He got to, anyone in the world could hear that story and say, wow, you did, a mitzvah, as we say in the Jewish world. Yeah.
I get it. So I think that's probably another thing, right? I think in general, we help. We're continuously helping, but probably we just take that as a routine part. And probably we don't even stop time to pat ourselves. Not in, this is a definitely commendable situation, right? But there are situations when we take time to sit down and hold the hands and look into the eye, and we're delivering that information to that patient about their diagnosis of a cancer, right? It isn't easy. When we do that, I think we should probably stop more and pause more and patter back a little bit, right? So that that can stay with us a little longer. That is also another positive thing we're doing for ourselves, right? Self-compassion. And then probably even that positive will reinforce and remind us. I don't know.
Yeah. We should.
So coming back to that, you said, I think, what are the things that I know we're talking about, we've talked about press caney, we talked about leadership, organization systems at higher, the administration, the situations that we're getting imposed, or the emergency room physicians and providers are getting imposed, right? That actually is expelling the compassion out out of the system or out of the physicians. But what are the things that people can start doing, leaders or all these Preskini? We talked about the positive metrics, right? That's one thing. What are
Yeah.
some of the other things you think they could start doing at different levels that will enhance this compassionate behaviors?
No, I'll start again back at what we can do individually. One thing I've been doing, and I could have maybe it just came to my head. I probably goes back to one of your further questions is, ever since having kids, I try to imagine again that these people were once that kid. And so that helps me a little ground myself. I think on like a systems level, things shouldn't be so black and white. It's not you hit the metric or you didn't hit the metric. The metrics should be there to show trends, not good or bad, yes or no. He did it, he didn't do it. It should show Bryn Mawr Hospital does pretty good at getting their TNK in a reasonable amount of time. They're pretty good at getting their antibiotics in a reasonable amount of time. They're a little bit slow on discharging their patients compared to the national average. Maybe that's something we should just look into why. Not, they did it in 140 minutes. Yes. They did it in 141 minutes. No. So I think numbers are good, but a focus on what the numbers mean could change. And then, it felt good as an ER doctor in COVID when everyone said thank you. And, we were those heroes, quickly forgotten heroes, but for a minute we were heroes. And so I think that just, everyone wants to be thanked. Everyone wants to be, told they're doing a good job. Everyone wants to have positive reinforcement or whatever. So whether it's administration or your colleagues, positive follow-up on cases, something you did well, it's always good. I think that can bring more compassion. And yeah.
It's kind of a ripple effect, right? I think if we receive, we tend to give it out quickly too, right?
Yeah.
So that ripple effect continues. Hopefully, we can start doing it ourselves too, and probably set out that as an example, right? But hopefully, the leaders of the nation will listen to this at some point, at least few leaders, and we'll take it from there. Anything else in terms of what things that you would want to discuss on this channel at this point?
I feel like I did a good job, kind of ranting and getting it all out to you. So I feel good. I feel like I'm ready to be compassionate. Let's do
I
this.
so love it. I so love it. I so love it. I'm going to ask you a few more questions, but like a rapid fire questions, just 5.
Okay.
And I think we'll have a few more questions after that. All right. If I say compassion, what's the one word that comes to you?
Empathy.
Okay. If I say self-compassion, what is one word that comes to you?
It's funny. The word that came to me is depression.
There's something that needs to be done around this, Josh.
Doctor.
All right. No worries. A book or a person or an incident that inspired you and stays with you for stayed with you?
Yeah, the one I kind of talked about. I had another one that's in a residency. It's somewhat of a long story, so I don't know if you want it, but there was one
I
in
would want to.
what's up?
Yeah.
This maybe I shouldn't bring it up, but I will. It involves some what today is considered very tough socio. Not, it's a very tough social issue today. But back in residency, I had a patient. I was at St. Christopher's. He was from the West Bank in Palestine. Jewish. I figured that, by the way. Not that that matters. I'm just throwing that.
Mhm.
He got sent. You get yourself feedback. Thank you. So he was sent many years ago as a young boy to get a prosthetic leg for Ewing's. And this is not HIPAA because his story is now out and about on fundraisers and whatnot. He was sent as a young boy, I think 8 years old, to Philadelphia. That's how he got into St. Chris for Ewing sarcoma from Palestine. And he ended up getting a prosthetic leg. He is now 13 when I'm in my residency, and he needs a revision of his prosthesis. He comes to Philadelphia. He's playing soccer just with like the local family he's staying with. And he's like acutely short of breath, cannot figure out what's going on. They bring him back to St. Chris and he's in like acute florid heart failure. I guess the chemo medicine that he initially was on caused cardiomyopathy. And it became, and this is my entire 2-month rotation, became about what do we do with this kid? And it was so sad. And, but basically, the issues were he needs a heart transplant. Can we give him a heart? There's only so many hearts in America. Should they go to an American boy or should they go to, someone that's not an American citizen? Okay. Let's say we solve that issue. He goes back to Palestine. Can they even take care of him? Do they have the follow-up care to take care of such a complicated medical situation? And we would make calls to hospitals in Israel, hospitals in Jordan, working on figuring out if this happens, can we get follow-up? We talk to hospitals in America. Can we get him a heart, et cetera? Ultimately, the decision was made that he was going to be flown back to Palestine to die with his family and that he was not going to get a heart. Then it was decided that it was too risky. He would die on the airplane. So we were going to fly his family here so that they could die with him or he could die with them. This has a good ending, I promise. We didn't speak the same language, but he loved soccer and I loved FIFA, the soccer video game. So we would spend many hours when I did 27-hour calls there playing at 2 a.m. soccer. His heart rate would get up to 160 or 180 if I was winning, and I had to let him score goals because I thought he was going to code on me multiple times. He ultimately, at the last minute, the University of Pittsburgh, my alma mater, again, go Pitt, hail to Pitt, stepped in, paid for a heart transplant or got him a heart transplant, paid for his family to come out here for a year. An entire post-op care would be taken care of, set up post-op stuff through Israel, so he could go in when he needed his post-op stuff. And because I'm a big Pitt fan, I went out to see a football game. It was before his heart transplant. He had just gotten an LVAD put in, and I went to the hospital, the children's hospital out there, and I saw him. And I got to meet his mother. Again, we didn't speak any language, but he knew who I was. He gave him a big hug and, donated to the society that, help initially help bring him out here and all that stuff. And I've since really lost track. I've tried to Google him once in a while and haven't, but presumably everything went well. He did get his heart transplant. I know that. He moved back to the West Bank and hopefully he's doing well. And so that was I don't even remember the original, but I think it was something about another story or compassion. That, that
No,
was,
but no, that is, I mean, that was intense. There is so much depth in this, right? I think you said you didn't speak the language, and still there was so much connection. There
yeah.
was so much. I mean, I use a lot of love as well. And I think that is what it was, right? That connection, that humanitarian aspects. And we don't need language for love and compassion to go beyond.
And I pointed out that I was Jewish. I think there was a reason I did that. No one is, you know, dense. There's obviously a big, issue going on in the world. And it just shows that there's like, so much more than our government politics or whatever causes these affairs. It was just me, a person, and him, a person, and a whole lot of was on our team too. But like, we liked each other. We played soccer. I cared for him as my job, and also, internally.
And yeah, I think that is where the beauty of that. I mean, sometimes I know we look at these big political situations and the unfortunate situations, and I don't know, we try to forget that we are just simple people at the end and just human beings, and it's so
Yeah.
unfortunate. I'm curious, and if possible, I would like to know. I don't know. I've not known about this situation, but what was the reason that Pitt finally came? And I'm very curious.
I don't know. Yeah, I don't know. It's been many years. Remember.
That's so beautiful, though. Yeah, that is powerful. All right. So, any more stories that you want to share with us?
That's it.
Not that. Okay. All right. So, if we want to, is there anything that you would want to take away from here? And is there anything that you want our listeners to, that you would suggest them to start doing one thing today? It's tough to keep up, I know, but we can't maintain that consistency. The consistency is tough. But if we want to be consistent,
I don't have advice today. I'm sorry. You know, yeah, I mean, I guess it's fun. The advice I would give is the same advice that like I should take myself. Like, put yourself in someone else's shoes. So I should put myself in those annoying patients' shoes that I get annoyed with. I have trouble finding compassion, and they should put themselves in my shoes.
I do completely agree. I think putting other, I mean, patients or our colleagues or like the administrative, like how you said, I do want to bring, I mean, I will also be having patients and family members on this show as well, and I want to get their angles, and hopefully they will listen to this and understand the situations or the troubles that we go through, and it's not like an easy job. And right, but there was another, so yeah. So basically you're not ready to give that's why I asked, what is one thing you want to take away from here? So all right, any more parting messages, or before that, is there one thing that you do on an everyday basis, any practice that you do on an everyday basis?
Yes, I go to every room and say the same ridiculous line. Hey, Dr. Brown, nice to meet you. Sorry we're meeting like this. Hope I can get you feeling better. So there's my empathy.
All right. All right. Any parting messages as we?
No, but thank you. I appreciate it. This was fun.
Thank you so much. I mean, thank you for taking time. I know there's so much going on in your life, right? Thank you and coming and talking to me and discussing all those aspects that limit us, right? And how we could probably start doing things differently, and how we can get the good things out when we are, and how to, what do you say? Not even the right term here. How to appreciate the work that our colleagues are doing, right? And how to take the walk by the leaders, and how Chris Caney can start looking into more of the positive things. So hopefully at some point when this channel grows, they'll start listening and if they take at least one thing, this conversation becomes even more meaningful. But I had a lot of fun.
Me too.
Thank you so much again.